Welcome back to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluation, which was the piece of paper that you got when you came in today. Also, if you could give the CME committee any ideas that you might have in regards to future topics or speakers, we're always appreciative of those ideas. Today we have actually several presenters. From the Department of Hematology Oncology, we have Dr. Debra, and from the Bliss Cancer Center, Mary Ellen Carano, from Pathology, Jamie Weydert, from Radiology, Grant Goldsberry, and from General Surgery, Ben Schlicher, and I believe Dr. Shane Hopkins will be joining us momentarily. They're here today to discuss with us the multidisciplinary care of the patient with breast cancer, and please join me in welcoming our speakers today.
So as Dr. Hallberg spoke, there will be several of us presenting different portions of a case of one of my patients. And if you've been with me any time before at any presentation, especially these two guys sitting in the front row, don't be shy about asking questions, and don't be shy when I ask you questions. So this is an interactive program to try and bring focus to the multidisciplinary needs of a patient with a breast cancer diagnosis. This particular young lady was 53 at the time of her initial diagnosis. She had had a mammogram done in March of 2013, and in July of 2013, she found a left breast mass. Her past breast history was that of having a prior right breast biopsy and multiple cysts being removed. She had no previous medical problems of any type. So I'm going to let our radiologist take you through the imaging.
So I'm Grant Goldsberry, for those of you that I haven't met yet at this point. We'll kind of run through some of the imaging here. For those of you that weren't at my previous presentation, we've made some kind of significant updates on kind of our breast imaging program here over the last year or so. So this initial mammogram was done almost 2 years ago at this point. So this was back at a time point when we were still doing just kind of our conventional two-dimensional digital mammograms at that point. So it was pre us doing kind of tomosynthesis or the 3D mammogram imaging, and also prior to us doing any of our screening breast ultrasound program. Basically the way the breast imaging screening programs are moving at this point is we're kind of moving from just a general population-based screening program to trying to tailor individual screening programs to more individual patients. So instead of just having kind of a standard one-size-fits-all screening program for everyone, we're trying to more tailor it to individual specific patients, and I'll show why that potentially would have made a difference for this particular patient. So this was her left breast mammogram that was performed back in spring of 2013, which you can see this was read as a normal mammogram, where there's no particular masses that you can see on this mammogram. You see the whiteness on here is what we describe as being her breast density, or breast dense tissue. For lack of a better term. This is the breast density scale that you may or may not have heard described previously. The ACR has designated 4 categories for breast density. That's categorized A, B, C, and D. Why this is important is it both impacts the interpretation of your mammogram, but also impacts the risk of breast cancer that you may have. So from a radiologist perspective, women that have a category A breast density, that's going to make detection of breast cancer on mammograms the easiest for your radiologist to detect. Those that have the breast density category D, that's going to make it the hardest for the radiologist to detect the breast cancer. The reason that is that way is cancers, masses, they show up white on your mammogram. So if you look as you move across this particular screen, If you look to the category D, you see the amount of white breast tissue that's on the D mammogram picture as compared to the A. So there's a lot of blacks and grays on the A picture. There's lots of whites on the D picture. So if you can imagine if there's a cancer in these four particular women, it'd be much easier for the radiologist to pick out in the A mammogram picture as opposed to the D mammogram picture. So that's important, obviously, for detection of cancer, but also risk stratification as well. So women that have dense breast tissue have a much higher risk of breast cancer, and at the same time have a less likelihood of having it found on a mammogram just because of the dense breast tissue. As Dr. Prow mentioned, later that summer, the patient actually felt a mass in her breast, so she came in for an ultrasound. And what we do when a patient feels a particular lump in her breast, we'll actually do a targeted ultrasound of that particular area. So when we did the targeted ultrasound of that area, what we found was this dark area on her ultrasound. So typically what the breast parenchyma looks like on an ultrasound is it should just have kind of this nice kind of gray appearance that you see in the surrounding tissue. The concerning features in this particular ultrasound is when you see this dark structure here where it's tall and has kind of this shadowing appearance to it. On a couple of some of the other slides as well, you could actually see where there's these kind of reds and blues. Excuse me. This actually showed up inside of this as well, which those are all concerning features. Subsequently, once we made that finding on the diagnostic ultrasound, she actually came back later on. Anytime we find a concerning finding like that on a particular imaging study, we as radiologists then proceed on to a biopsy. The biopsies are always performed by the imaging modality that the suspicious finding is uncovered. So in this particular instance, the imaging finding was discovered on ultrasound, so the biopsy is performed by ultrasound. In breast imaging, obviously we do MRIs, we do mammograms, and we do ultrasounds. We can do biopsies under all those different imaging modalities. We generally default to whatever the easiest biopsy modality is for how we imaged. So ultrasound biopsies are generally the easiest for us to perform, so that's our first preference for doing biopsies. So if we can see an abnormality within the breast with ultrasound, that's our first preference. Stereotactic biopsies are ones that we visualize with mammogram pictures, would be our second preference for biopsies. And then our third preference would be MRI-guided biopsies. Those tend to be kind of logistically the most difficult biopsies to do, but occasionally that's the only way we can see pathology in the breast. So we can do biopsies that way as well. It's just logistically a little bit more challenging to do biopsies that way. So in this particular patient, we did an ultrasound biopsy. What we do for the surgeons afterwards is we actually place a clip in the breast after we've done the biopsy, and that just helps us localize exactly where we've done the biopsy within the breast. In this particular patient, she proceeded on to a mastectomy. If the patient had a lumpectomy, what we would actually do for the surgeons is we'd actually place a small wire to localize where this clip is, and that's how the surgeons have some guidance as to where to do the particular lumpectomy if in a particular case the patient would proceed on to a lumpectomy. Again, in this case, a mastectomy was performed, so that step was not performed in this particular case.
So really expensive grand rounds. You got radiology and pathology and surgery and oncology. It's and I don't know where the money for the pizza came, but I don't know if we can afford this. Anyway, so this is the pathology of this scalp. But before I show you the H&E picture, which is on the right side of the screen, I want you to look at the lower left. This is an example of what kind of biopsies are taken by Grant and his colleagues in radiology. This is actually not the patient's biopsy, but gives you a good kind of feel for what it is. These little square white cassettes are a couple centimeters by a couple centimeters, so you get a good amount of tissue with the current biopsy techniques that radiology uses, and it's come a long ways to when these biopsies were first being done, where we get smaller pieces of tissue. Now we get actually quite large pieces of tissue to look at. One thing that comes up sometimes, we get a question about it, and I know Dr. Prow gets questions from our patients. When a patient gets diagnosed with a breast cancer via image-guided biopsy, the question is, well, why is a pathologist doing the estrogen studies and the progesterone receptor studies and the HER2 studies on my biopsy? Why shouldn't they wait until the cancer is cut out? And that's a good question, and the answer to why we do it on the biopsy is to expedite planning. In this particular case, this gal ended up being triple negative, which has very significant prognostic and predictive features for the patient in her management, as we'll see in a little bit. Number two is that when we do these studies on tissue, the estrogen receptors and progesterone receptors and the HER2 new studies, those studies are very sensitive to formalin fixation time, meaning how long the tissue sits in the formalin fixative before we process the tissue. For biopsies, we can control that time almost to the minute. When the biopsy is done, it goes immediately into a jar of formalin, and then it comes to the lab, and then we process it. So we can control that very nicely versus a resection, like a mastectomy or a needle localization biopsy. There's a lot more slop, to use a colloquial word, slop in the whole process as far as when it gets from the patient to the formalin fixative, how long it sits in fixative, how long is exposed to the fixative on the cut surface of the tumor. So we prefer to do the prognostic and predictive studies on the biopsy. It's just better analytically, and it helps kind of get the ball rolling for treatment planning. Now, in our patient's case, she had a very, what we call high-grade tumor, and that's seen on the right. This is a H&E photomicrograph. This is what I'd be looking at underneath the microscope. The blue dots here, these are all the nuclei of the cells, and blue is usually bad. So blue usually means lots of nuclear mass, usually lots of big nuclei in a tumor. So blue is bad. So you see a lot of blue here. And these blue dots, they're all different sizes and shapes. That's also bad. Differing sizes is bad in pathology. So lots of pleomorphism, meaning different sizes and shapes. Lots of blue. There's also some pink. The pink is up here. This is some necrosis where the tumor actually dies. It grows so fast that the middle of the tumor kind of says, oh, I give up. I don't have enough nutrients, and dies. So we actually have necrosis, which again is another sign of a high-grade tumor. So she had a grade 3 tumor. And grading is done histologically. There's 3 grades, 1, 2, or 3. 3 is the highest, usually correlating to a more aggressive type of tumor. Importantly, stage is not done histologically. Staging is where we have to look at the extent of the tumor within the body, and that's best done after the patients have their definitive surgical procedure, whether it be a mastectomy or a conservation lumpectomy. We put it together, the radiology, the pathology, the staging information from surgery, and put that all together as one final stage. So that's another thing that sometimes gets mixed up. A patient might say, well, I had grade 4 breast cancer. She probably means stage 4 breast cancer, because there's only 3 histologic grades of cancer. But those two things, grade and stage, are often flip-flop by patients. So it's important to remember the difference. Grade, what you see in a microscope. Stage is the overall picture.
So one of the ways that I talk to patients in regarding to what is stage is how much cancer is in an individual's body. This particular patient is young, and she has triple negative breast cancer, which makes us very concerned about a potential genetic risk. And if she has a deleterious mutation, that's going to change her recommended course of treatment. So she was, as soon as we had that path back showing triple negative breast cancer, she was referred to a genetics counselor for evaluation of genetic status. So this is Mary Ellen, who's our genetics counselor.
Hi. It was kind of interesting with this situation because actually we do breast navigation and other navigation services, and this patient was referred to us by the primary care provider, and based on navigation service, knowing that she had that same day an appointment with an oncologist, and knowing who her oncologist was, it's kind of like, okay, well, I know this oncologist isn't going to want to do anything until genetics is done, and knowing she meets criteria. So this was really a perfect example of navigation services that went into genetics and the way the process is supposed to work. So at the time of her appointment with me, it was 7/19. And big question with all genetics, especially pre-surgical, is how can we get this done and get it done quickly? If you look at the pedigree here, you'll see the patient, oops. I don't know if I have a marker. The patient is here, and it identifies her age of diagnosis at 53. The key factor in her age of diagnosis is not the age 53, but the triple negative status. Anyone diagnosed at the age of 60 or below triple negative would meet criteria for BRCA testing. We look at her pedigree too, and talking with her, she's like, there's really not much breast cancer in my family. So I really require that they do sit down, take time, and do a family history form, because often in that visit, they don't know much about their family history, and they have to ask other people and get more information. So as she talks, her dad had a lung cancer. Her paternal aunt had a young age breast cancer, and then paternal grandmother had average age breast cancer. So nothing really high risk other than the one aunt and then the patient's age and then the triple negative factor. You would also look at the fact that this is a small family size, not a lot of females there, which can obscure the look of an inherited breast and ovarian cancer family. So we look at who do we evaluate and when and why. And so basically we'll cover a little bit about the history, patient's history. These are from the NCCN guidelines. Any woman with a breast cancer diagnosed prior to the age of 50 would meet criteria for testing. Any woman diagnosed with triple negative breast cancer prior to 60 meets criteria. Ovarian cancer diagnosed at any age would meet criteria regardless of breast history or other history. Male breast cancer automatically meets criteria regardless of age. And then having a relative with a male breast cancer, obviously looking at the patient's history as well. And people of Ashkenazi Jewish descent have a very high risk of BRCA status, so that raises the incidence even higher. I was recently reading that in the white population, 5% of people of Caucasian descent have BRCA mutations. In the Ashkenazi Jewish population, 12% have BRCA mutations. There's been some recommendation that all individuals of Ashkenazi descent have BRCA testing because it simply is cost effective to do that and identify their mutations early. That's not standard at this point. What type of family history do you look at? Well, you're looking at the best person to test is always someone who has the type of cancer associated with the syndrome. That's not always possible. So if we have a young person who, say her mom died of breast cancer prior to the age of 50, she no longer is living, she's a candidate for testing. So it's based on her family history. Family history member diagnosed with ovarian cancer, most likely you're going to see some of the other correlated cancers for these syndromes. Have 2 or more breast cancers diagnosed in the same person is automatic testing criteria. Male breast cancer again. And then having 3 or more relatives with hereditary breast ovarian cancer syndrome associated cancers on the same side of the family. So sometimes we'll end up having women who are all diagnosed after age 50. The identified patient, maybe she's 60, and she has 2 sisters who are, 55 and 78. That family would meet criteria just because of the numbers. And then anytime there's a family member who has a BRCA mutation, those family members have a 50% risk of it inheriting. And then we're going to do single-site testing exactly where the mutation is located. This has been a year and a half of just explosion of genetic tests since BRC came off patent. And so we work with primarily two companies, Myriad, which is a long-standing company, and then Ambry, which we do a lot of panel tests, and Ambry really took up the slack when BRCA was open through Myriad. Integrated oncology is one that the hospital uses, and they can do BRCA. We haven't decided to use them as another company, but this is, again, just exploding. So BRCA 1 and 2 are really the highest risk cancer or genes associated with breast cancer. In the last year, there was an identification of a PALB2 mutation, and this was felt to be the second most high risk associated cancer for inherited breast syndrome. It's a BRCA modifier gene, mainly BRCA2. It really works more like a tumor suppressor gene. So I was going to just quote you what the number is on risk in PALB2 gene mutations. So women have about a 14% risk of breast cancer by age 50 with a PALB2 mutation, and by age 70 they have a 35% risk of breast cancer. So that again is very high, and it's another thing that we're beginning to look at when we do straight BRCA 1 and 2 through Ambry or Myriad. It does not include PALB2. When we do panel test, it does include PALB2. Now, panel tests are the next generation sequencing, and those are more complicated, looking at a much larger range of genes, not just breast and ovarian, but colon, a lot of these BRCA modifiers, maybe even like Fanconi's anemia, things that were Cowden syndromes. We're looking at big panels. They're looking at about 28 genes. I can say that they can be a good test. My risk, I'm going to go really onto the cost of these, and this all comes into factor when you're ordering tests, what tests to order, because there's so many more now. The biggest thing for most of the patients we see, like this patient, is we want the testing done fast. And when these panel tests came out, they often took 6 to 8 weeks, sometimes 12. That's too long. It's too long for our patients. We maybe get more answers, but we don't have that time. BRCA with Myriad, I can ask them to request it to be expedited. There are times that I've gotten that back in a week, more often 2 weeks. Using Ambry, they're quoting me 10 to 14 days for BRCA 1 and 2, but the time factor is a huge process in getting these patients onto surgery. So mostly in these early making diagnoses, helping patients to make decisions, we're going to do BRCA 1 and 2. If we have more time, we'll do often the panel test. There's kind of questions in panel testing right now. A lot of panel testing is showing us answers in gene mutations that isn't what we were requesting or looking for. So it's really, again, a process of gathering information. We're also getting a lot of variants of uncertain clinical significance. Those are problematic for us and for our patients because we don't really know what to tell our patients and how it affects their risk. So there's even questions on how to deal with those variants. Obviously, clearly, when we have a mutation, it's very helpful for the patient. As I said, BRCA 1 and 2, just checked the other day, runs $4,040. We can get that usually in 2 weeks or less. Ambry can do BRCA 1 and 2 for $2,200, much less cost. That's a factor when you're ordering. I like Myriad because they get me things fast, and there's a lot of data there in the research they've done before anybody else has begun this process. The panel test, my risk is really looking at 25 genes associated with BRCA 1 and 2. Myriad has promised that they can get us back that test in 3 weeks. So it's going to look at all those high-risk genes. It's a good test. It's at the same time now. It's costing the same as BRCA1, the BRCA analysis. I will tell you that I don't always get it back in 3 weeks. I know if I'm going to do BRCA1 and 2, I'm going to get it back quickly. So it's kind of a call, and you have to look at what else is going on in that family. Most of the panel testing are going to run between $1,500 and $3,900. The $1,500 is out-of-pocket cost to the patient. And then they're going to take longer, 4 to 6 weeks. So they've really gotten it down in panel test. We do have Angela Long, who's our patient breast. She's a certified nurse breast navigator, and she does most of the navigation on our patients now. We like to get the navigator involved with these cases early. She can establish relationships with them, help them, with anxieties and fears, and really educate to them to what to expect. She does a great job, and she really builds those relationships. This patient did end up having a BRCA1 mutation, and it did cause her a lot of grief in that process of delay, because it ended up, we started out hoping for under 2 weeks. It took 3 weeks, but it obviously made a huge impact on the decision she made for surgery.
Okay, so a good segue into breast surgery as it relates to breast cancer. So a lot of times when patients come to our clinic and they have a diagnosis of breast cancer, a lot of times they actually have an option of what type of breast surgery they have. There's 2 main options. One is our breast conserving therapy, which is typically our lumpectomy, where we remove the breast mass itself, a small amount of normal tissue around it. That's typically done with radiation. The second option is a mastectomy, where we're essentially removing about 95% of the breast tissue on that side. The breast conserving therapy, the lumpectomy, that's much more common in most patients. A lot of patients like that because the incisions are smaller, the dissection is a little less. The potential complications are lower. It's an outpatient procedure, and patients typically have minimal pain with it. Comparing that to a mastectomy, where it's a little bit bigger incision, complications are a little bit higher, typically in a hospital for a day, maybe 2, and you're typically going home with a drain for about a week or so. So most people often will qualify for the lumpectomy, and they choose that over the mastectomy. Now, there are certain occasions where we would recommend a mastectomy over a lumpectomy. So if a patient has breast cancer in 2 separate areas of the breast, a mastectomy would be more appropriate. If they have a breast cancer that's just underneath the nipple and it'll be difficult to get negative margins, that would be another reason. Other patients, if they have a large breast mass compared to a smaller sized breast, that would leave a significant cosmetic defect, and patients would often choose a mastectomy at that point. Other reason would be to, if they have a reason to avoid the radiation that typically accompanies the lumpectomy, that would be another good reason for the mastectomy. Now, comparing those 2, looking at recurrences and overall outcomes, with the recurrence level with the lumpectomy, that's a little bit more common to have a recurrence. That rate is somewhere in the range of 8 to 9%. Recurrence with a mastectomy is lower at roughly about 2%. However, if you look at comparing those 2 groups over the long period, typically their outcomes, their overall survival rates are the same. So we consider them to be essentially equal surgeries, and both would be good options. Often when we do a mastectomy or choose a mastectomy, the patient will ask, well, what do I do with the breast on the other side, the healthy breast? And a lot of patients are asking now for a prophylactic contralateral mastectomy. These rates are really going up, especially over the last decade or so. We're not really clear, what is driving those numbers up, but I think a lot of it is seeing more of it and talking about it in the media. And I think women are just more aware now that that's an option. A lot of women will say, I have breast cancer on one side, just remove the other one as well, and then there's no way I can get breast cancer.
And that's not entirely true. You know, when we do a mastectomy, we cannot remove 100% of the breast tissue. They still can get a breast cancer after a mastectomy, but the mastectomy will decrease their chance by a significant amount, usually about 90%. So when patients talk about a contralateral mastectomy, that's typically a conversation that we have talking about the increased risk of doing more surgery, more dissection, potentially increased complications with that, and trying to balance it with their breast cancer risk assessment. So, you know, a lot of patients will ask, if I have breast cancer on one side, in most patients, you know, what is the chance that I'll get breast cancer on the other side in the future? And that risk is somewhere between, we believe, about 3% and 9%. And those numbers are a lot lower than what some people would expect. So in our patient, she was positive for BRCA, so her risk of breast cancer on the opposite side was significantly higher. So that's why our patient in this instant chose the bilateral mastectomy. When you do a mastectomy, there are options for plastic reconstructive surgery. So I do not do this, but just to briefly mention, sometimes we can do reconstruction starting in the same procedure as a mastectomy. It can also be done delayed too, months or even years down the line. Occasionally we will do tissue flaps in the area, but a breast implant would be more common with that. And some patients will choose, if they have a mastectomy on one side, often there is an option to doing potentially a reduction on the other side, and a lot of patients are pretty happy with the cosmetic outcome with those as well. When we do breast surgery for breast cancer, especially with an invasive breast cancer, we also want to assess the lymph nodes on that side to see if any of the breast cancer cells has transferred or spread into the lymph nodes in that axilla on that side. In the past, we've done a lot of axillary node dissections where we remove all the lymph nodes underneath the axilla. There is a risk of lymphedema with that. That's about 15%. There's also potential complications with that as well. We have learned how to do sentinel lymph node biopsies, which are a little bit easier for the patient. The sentinel lymph node is the first lymph node or a couple of lymph nodes that drain the breast. The day of the surgery, typically we'll do 1 or 2 injections in the breast. One's a blue dye, and one is a radio-labeled marker that we would inject into the breast. During the surgery, we can use those to find the sentinel lymph node. We're usually pretty good at finding those about 97 to 98% of the time. There are a few false negatives with that, though. With that, during the surgery, we'll take that sentinel lymph node and we'll send it to pathology, and they'll be able to do a frozen section to tell us if it's positive or negative. If it's negative, we're typically done at that point. If it's positive, we're still doing axillary node dissections where we're removing the rest of the lymph nodes if it's positive. Now, occasionally, you can have with that frozen section, you can have a false negative. You know, the frozen sections are not 100% accurate, and I always tell patients that. The false negative rate on those frozen sections, kind of depending on where you read and how you define a positive lymph node, but that rate is somewhere in the range of 7 to 10%, which I think is actually pretty good. That's fairly low. This patient actually had a negative frozen section, but later on final pathology, it was positive. With sentinel lymph nodes, so typically if the lymph node is positive, we'll do a complete axillary dissection. There has been more research coming out lately kind of challenging that, and we're learning that these axillary lymph node dissections may not be as helpful to patients. So a few years ago, there was a big study looking at a certain subset of patients with breast cancer. If they had a positive sentinel lymph node, they randomized those into patients who just had the sentinel lymph node compared to those who had axillary node dissection. And the overall outcome, the overall survival rate was the same with those two. Recently, there's been other studies coming out. One study looking at sentinel lymph nodes, if they're positive, comparing patients who had an axillary node dissection compared to patients who had a boost of radiation. And longer term, those survival rates have been the same as well. So we're starting to get more information telling us that the complete axillary dissections may not be helpful, as helpful to the patients. And if we can avoid that, your risk of lymphedema with the complete dissection is about 15%. Sentinel lymph node only, that goes way down to 2%. So I think that we're in the process. I think that is starting to change. I think in the future we're going to do a lot less lymph node dissections, and we'll probably see less lymphedema in the future. So our patient did undergo the bilateral mastectomy with a sentinel lymph node, and she did get breast reconstruction.
Hi, Sarah. How are you today? So we're going to flip back here just a little bit to this pathology. Sarah's going to help us out here. So this is a 53-year-old lady. She's postmenopausal with triple negative breast cancer who's BRCA1 positive. So she has a PT1C. Her primary tumor was 1.2 centimeters. She had one lymph node with microscopic tumor cells in that node and no evidence of metastatic disease. So my question to you, if she otherwise feels well and her laboratory studies were stable, what would be her indication for further imaging? That's a fair question. You guys can help her out.
If she otherwise feels well?
Yep, so she doesn't have headaches, she's not having seizures, she's not coughing up blood, she's not jaundiced, she doesn't have pain over her liver, and she has no bone pain.
Not sure.
Yeah, so there's really no indication for PET, CT, or other imaging for someone with a stage 1B tumor in her situation. Now, Dr. Weydert showed you her initial biopsy, but the other thing that's important from my perspective that goes along with what he's saying is the Ki67, which is high at 60%, and that just reflects the aggressiveness of this tumor. So she has a stage 1B disease that we know is BRCA positive, and the question now is, she's completed her surgery. What do we need to do from an adjuvant standpoint to avoid this cancer from coming back and recurring in the future? And is there a role for chemotherapy, radiation therapy, hormonal therapy, and what lifestyle and potential medication changes can be helpful for her? So she definitely has an indication for chemotherapy due to the aggressiveness of this tumor and its triple negative status. It's a bad actor. Radiation therapy is difficult, and Dr. Hopkins will explain how he and the patient made the decision they did regarding hormonal therapy, radiation therapy. There's no role for hormonal therapy or manipulation in an ER-negative, PR-negative patient. Her disease is HER2 negative, so there's no role for any HER2 positive tumors. So she was offered standard of care, which in general would be anthracycline-based chemotherapy or non-anthracycline-based chemotherapy, versus a clinical trial. And at the time of her diagnosis, an NSABP trial, B49, was available. That was a 3-arm comparison of different regimes, either anthracycline or non-anthracycline containing. The importance of that, anthracyclines have been the backbone for breast cancer chemotherapy for years. They have 2 really bad side effects. They can cause heart muscle damage, and they can cause acute leukemias in the future. So if you don't need an anthracycline, you'd really not like to have that exposure. So she was ultimately went through the informed consent process, was enrolled and randomized on this trial to Arm C, which was dose-dense adriamycin cytoxan times 4 cycles followed by weekly Taxol times 12 through that time frame. The cardiac toxicity from anthracyclines usually occurs when you hit 410 milligrams per meter squared. Her lifetime exposure is 240, and we monitor that throughout patient's life. So then the question became, once she's completed her chemotherapy, what is her role for radiation? So I'll pass that off to Dr. Hopkins.
Thank you. So radiation for this type of patient is about the same now as it was for the last few decades. One of the reasons we chose this case is because it could showcase some of the advances in the different disciplines. For the next few slides, I'm going to show you some of the advances in radiation, but in her particular case, she gets the kind of standard radiation that's been for a long while. So some of the advances, as Dr. Schlicher mentioned, is who needs the radiation, and whether they can get away with not doing radiation. Post-mastectomy radiation, there's some clear indications, but then there's also some gray areas, and she's in the gray area. If you had some physicians see this woman, they would say, you don't need any adjuvant radiation. Generally, I think most radiation oncologists around the country would recommend adjuvant radiation in a situation where there's pathologically involved lymph nodes. And then, my standard approach is to have a discussion with the woman who is making the decision so that she understands what the benefits are of the radiation. For example, in this particular case where there's a small number, or in this case one, involved lymph node, there's a meta-analysis a couple years back that showed from 22 trials post-mastectomy radiation, you had a 20% reduction in breast cancer-related deaths 20 years out from the radiation treatment when you compared those who got it and those who didn't. And so that's a reasonable reason to do the radiation. I think a lot of people go that direction. However, there is considerable toxicity to radiation, especially when you're involving the lymph nodes. And so you have a discussion about that. The lymph nodes, if we target all of the lymph nodes, including the internal mammary nodes, the axillary nodes, the supraclavicular nodes, you can have lymphedema up 40% of patients, and it can be significant lymphedema. It can be very difficult and affect the quality of life. Very difficult to control. However, if we just make some slight adjustments to the fields and exclude the internal mammary lymph nodes and axillary lymph nodes, you still have really good control rates with a supraclavicular and infraclavicular lymph node coverage that drops that lymphedema rate down to 3% on one trial at least. And so there's different ways that we can adjust and customize the specific fields for the risk level and the comfort level in the decision that woman wants to make for herself. And I think that's where it gets a little bit nuanced. And so, like I mentioned, she did get kind of the full month. She got the 50-40. That's the longer conventionally fractionated radiation to the chest wall. These days we are able to do shorter treatments. We're able to switch around the positioning so that ladies can have their radiation in the prone position where they have an intact breast and the breast falls away from the chest wall. I wanted to show you that. So I kind of snuck in here some stuff that's not relevant to this particular case, but I want to show you how the discipline is changing and some of the ways that these things are moving along. So now, this is not intended for you to read. This is just intended to dazzle you. So there's a lot of criteria that go into whether a patient is eligible, for example, for the hypofractionated, where they get 3 weeks of radiation instead of 5 or 6 weeks of radiation. This is patient selection for accelerated partial breast irradiation with brachytherapy, which is where they get 1 week of radiation. They have to come in twice a day, and that has to be planned ahead of time, coordinated with a surgeon so they can get the catheter put into the breast. But you can see it gets a little complicated. It's not something you can just, I would expect the surgeon or the medical oncologist just say, well, this is what I think you should do. You can either choose to see Dr. Hopkins. I'd like him to come in. We can sit down and talk about it, have that conversation. So this specifically is patient selection for the APBI, not for this patient. But so second of all is positioning. This is an advancement. Just in the last couple of years in our clinic, we've been doing patients in the prone position, especially for larger ladies. The separation, the distance between the entrance of the radiation into the body and the exit of the radiation, that distance makes a big difference in the hot spot, how much you have to give. And if it's a larger woman lying on her back, look at the distance between on the right-hand side of the screen there, the distance between the mid-axillary, or the sternal line here all the way back here, this is a very large distance versus, from this point to this point. So when it's possible, this allows the breast tissue to fall away from the chest wall. There's going to be fewer hot spots. There's no direct lung radiation or heart radiation in the prone positioning. However, you're not able to target the lymph nodes in that position. So this woman was treated in the supine position. So this is not her scan, but this is an example of how you would cover the lymph nodes as well as all the breast tissue. She obviously is a post-reconstruction, and so you would see a lot different. Usually when there's a tissue expander, it changes. The breast is exphytic. It pokes out a lot more, and so that changes the hotspot and the contours and the way that the radiation is going to be on the skin. And then the last thing is just dose. We've learned over the last several years that we can get away with doing a lot less dose in some women. Now, in women who are really high risk, you can't. You have to give them the maximum dose, which is basically what we've been doing for years. So this woman got the maximum dose to the whole chest wall, but the boost, there's not a lot of data for boost in post-mastectomy radiation. It's not really well supported. There is really good support for a boost in women with intact breasts with invasive cancer, not so much for DCIS. So it just, again, it gets very nuanced. And so you have this discussion about what the benefit is. So some of the doses to the whole breast, you can go 25 fractions, 28 fractions, drop it down to 16. If they're younger than 50, they're not eligible for that. If they're older than 70, you might say they don't need any radiation. There's lots of different little things that's hard to keep track of. And then just to be clear, when I say boost, I'm talking about a small area of radiation to the tumor bed itself, because that's the area where most of the local recurrences happen. And so that's the area where you give a little bit of extra dose of radiation. It doesn't increase the fibrosis risks, the lymphedema risk. It doesn't really increase those significantly, but it will have a dramatic impact on the local recurrence risk. So that is kind of just a little snapshot into some of the ways that we've been changing our breast cancer radiation treatments.
So you can see from this particular patient's situation how much different interdisciplinary work is required to take total care of the patient. And it doesn't end there. It includes all of us in this room, the patient, their family, their support system, everything. This patient has BRCA1 positivity, so she ultimately was seen by GYN and underwent hysterectomy and oophorectomy after her breast cancer was treated. And fortunately, all of that was benign pathology. We talk a lot in our survivorship meeting about obesity, exercise, healthy lifestyle with avoidance of alcohol and tobacco, and of non-necessary medical imaging, and survivorship is really important. So, Brindy, how are you today? What thing have we not talked about in regards to this patient and her family? She has a genetic risk that ultimately led to this diagnosis. And if you'll remember on Mary Ellen's family slide, there were 2 spots below this patient. So she has a 26-year-old child and a 17-year-old child. So what haven't we talked about?
How her genetic mutation would affect her children or grandchildren.
Yeah, so the big weight on this patient wasn't so much her cancer and her situation, is what is the status of her children. And her daughter was positive and is being monitored and followed by us as well. So there is a special plan that we have for people with deleterious mutations of how we follow them based on their age. So that daughter is being followed in our clinic as well. It also brings to the point of the need so much for this team approach, which includes all of us, but especially the breast navigator, because they're able to be an individual to help get people through this whole process. You saw just how complicated the whole procedure is. So that's such a very important position that Angela does for us. Questions?
I know recently you went to the San Antonio Breast Cancer Conference. Dr. Prow, do you want to comment a little bit on lifestyle behaviors post-diagnosis and risk of recurrence, and why we are focusing a lot more on that with our patients?
Being fat is really bad, okay? And it's easier to make that point in patients who have ER/PR positive cancers, because the fat tissue actually makes estrogen that can cause their disease to be worse. And if you have a body mass index that's greater than 30, you markedly decrease your overall survival related to your breast cancer. It's also been shown that exercise is markedly beneficial. And so those things are just really important, the healthy lifestyle activities. So getting up and moving is good. Sorry about the pizza, I didn't know that was ordered. It's not on my diet plan. What else can you guys think of? Yes, sir. Right behind you, Emily.
This is for Shane. So on that patient, you said that it's better to do the supra and infraclavicular nodes than the axilla, where the node was positive?
So, they are axillary nodes, but usually when we talk about axillary nodes in radiation, we're talking about the field going a little bit more lateral, immediately below the humeral head. And so for whatever reason, that's just 2 or 3 centimeters of tissue. When you radiate that area, it increases the risk of lymphedema quite dramatically. And so yes, when we exclude that and we do a supraclavicular field without the more lateral portion, it has a fairly big difference in terms of the lymphedema risk.
I didn't understand that, I guess.
Sorry, didn't answer what you were asking?
Oh, yeah. I just...
okay.
It seems like we're doing a sentinel node, and that's like the lowest node in there, and that being positive, then the next node being positive should be the next one up if there's others, and we're not really radiating them. Am I correct? Am I understanding?
Well, we are radiating them. It's just I'm calling an axillary field the traditional radiation field. So I wish I had an illustration I could show you a little bit more clearly. When we have tangential fields coming in from the side, there's a top edge to that. So some of the axillary nodes are included in the tangents. Probably most of them are included in the tangents. But if we truly want to go up into the supraclavicular, hit level 1, 2, and 3 of the axillary nodes, then we have to put on this additional anterior field. So the beam is now coming in from the front. Sometimes you put a little patch on the back as well to bring up the dose. And so it's just, we're limited by the physical properties of light. You got to get the dose where you want it to go. And sometimes you get it places you don't want it to go. And you have to balance those two out. Is it worth it to get this extra little bit, knowing we're going to get a lot more of the regular tissue? And so I'm using the term axillary field because that's what is used in the radiation oncology literature and the discipline, but we're not missing the axillary nodes. We're treating the axillary nodes in there.
Gotcha. Thanks.
I'll ask 2. And I don't, Dr. Prow, did I hear that all the genetic testing is out-of-pocket expense?
No.
Mary Ellen said something.
Yeah, oftentimes the patients will have some portion of a copay to make. With that, it depends on the insurance carrier. And unfortunately, they're improving over time, but there's always a delay from new data to when the insurance carriers will cover a particular testing. So if we could have our pick, anyone with triple-negative breast cancer, we feel is an indication, but they're only doing that now for age 60 or below.
Okay, and a question for Shane on radiation. If a patient chooses to have immediate reconstruction, does that make it, if they're a candidate for radiation, does that make a difference? Do you wait longer or risk of the radiation and so forth?
Right. So it turns out that radiation really will mess up a reconstruction in various ways. And so the kind of reconstruction and the strategy for the timing of that is something that should be discussed with all the stakeholders. So you got to get the plastic surgeon, you got to get the radiation oncologist on board, and these decisions have to be made because, often I see the patient after all the decisions have been made, and then I'm stuck sending the patient back saying, you know what, this is really suboptimal. Now we really need your tissue expander to be deflated for the radiation, or we need to not wait wait for the tissue expanding for several weeks while, it's ideal if the tissue expansion can happen during chemotherapy. That's great. There's lots of different approaches, but we just need to make sure that everyone's on the same page, because the radiation will cause an increased risk of fibrosis and contracture of the breast. And so, if it's a flap reconstruction, that's usually a lot better, because then you're pulling non-radiated tissues into the field, and those are going to heal nicely. But if it's radiated tissue and you try and do surgery afterwards, then it's going to not heal well, and it's going to have scar tissue that really deforms the breast. You have a poor cosmetic outcome. And so that's a great point that, part of this multidisciplinary coordination needs to happen up on the front end. And similarly, a decision about mastectomy versus breast conservation therapy. If I find out the patient's not eligible for radiation, that's important to know before they went for a lumpectomy and now they got to go back for a mastectomy, that sort of thing. So.
Dr. Prow, you mentioned following the daughter. Is there a consensus on the recommendations to her, and could you comment on contraceptives in pregnancy?
Yeah. Dr. Grabenstetter knows I'm not very liking hormonal manipulation against Mother Nature. So the newest guidelines for BRCA1 positive patients right now are at the age of 18 years, breast awareness. At 25 years of age, every 6 to 12 month clinical exam by a physician. Age 25 to 29, annual MRIs. And from age 30 to 75, annual MRIs and mammogram. And greater than 75 years of age, that's individualized for that particular patient. Mirena IUDs are probably my most favorite thing for contraceptive for like this patient's daughter, who is also my patient because I follow both of them. So that's what I would usually lean toward, because she just got married before she was diagnosed with her BRCA positivity also. So, and then you're into the field of her having children as well, and what that means and what is that risk, which is where Mary Ellen and Angela really helped me out. This patient's daughter just recently had abnormal MRI imaging, had to go through biopsies, so it was all right back in her face again. So life is tough for her right now, but the biopsies were benign, so we continue. The other question that comes up is, when is the right time for bilateral mastectomy in these patients that are positive and don't have a cancer diagnosis, or their GYN surgery? And that's usually after age 35 is kind of the recommended age. Any other thoughts or questions?
I have one.
Yes.
They say that breastfeeding can help lower the cause of breast cancer. Is that the same for people that are tested positive with the BRCA?
I've never seen anything to not make that be true. I've never seen any specifics of that. Have you, Mary Ellen? It's good for you anyway. It's worth 1,000 calories a day. Yes, sir.
Are the male children and other male descendants of a breast cancer patient at greater risk for a breast cancer, and to what extent, if so?
If they're BRCA positive, yes. Okay. Otherwise, no, if it's not genetically related. All right, have an excellent day. Oh, one more thing before I forget. I need to say great thanks to Tim, who over the last several weeks has worked really hard to make this all work.